All right, good morning, everybody. We are going to go ahead and start our next panel. All right, a couple housekeeping points quickly. So, as you know, the secretary will be here this afternoon. So we will be breaking for lunch. I'm going to do my best to keep us on time so everybody can enjoy their lunch. That third roundtable is going to begin after the secretary's remarks, and his remarks should end around 2 p.m. Okay. If you do leave the building for lunch and plan on returning, please make sure you give yourself enough time to get back through security. That may take you a little bit more time than you think. There is a cafeteria around the corner if you prefer to stay in the building. And if you plan on being here for the secretary's remarks, we just ask that you're in your seats before 2 p.m. when his remarks should start. All right. We lost a few people, but thanks for everyone else for staying. My name is Jason Funderburk. I'm a Deputy National Coordinator, and I'm actually a practicing physician as well. We're going to continue with the theme this morning. I will tell you that if you have young children, and I do, in sports now, they do walk-up themes for a lot of things, and in baseball, they have a walk-up theme. I think after this morning's talk, the O&C walk-up theme is going to be bringing sexy back. So we'll stick with that one. I really want to appreciate all the comments that were made this morning, in particular the very powerful stories that we heard from Mr. Kennedy and Ms. Burgum, as well as some of our providers, Senator Marshall and Dr. P. Crowan from Louisiana, as well as the public health officials. I think those stories were all very compelling, and they illustrate how health information technology can improve and is improving behavioral health care delivery. But I think it also begs a couple additional questions. What else can be done, and how do we scale that for all communities? So for my esteemed panel today, we're going to allow everyone to do some introductions to give you their background and better explain how we're going to focus on a few things like current examples of EHR-enabled care coordination, the role of AI in improving both clinical and patient outcomes, as well as program and policy conditions that are needed to expand access to all these effective tools. So with that, we'll start with Mr. Steve Herron from Oracle.
Hi, Steve Herron from Oracle. I've been with Oracle Health for 31 years. In that time, it's been my job to basically adapt and implement the technology that everyone knows from the acute and ambulatory spaces into venues outside of those spaces, so specifically in post-acute, behavioral health, and all of the areas that basically haven't received the meaningful use funding or anything to implement the technology. So in most cases, when providers in these spaces have implemented, they're doing it for other reasons. Either they're doing it for something that helps to drive the benefits of the local program that they're operating in, or state local environment that they're in, or for better reasons of actually doing a better job of tracking the patient's condition. And so that's kind of what my role is. And I guess I'll mention too, in the previous session, I really appreciated Senator Marshall's comments in the idea that, providers haven't loved their EMR. And so that's one of the things about meaningful use. It did a great job of digitizing the record. But on the flip side of that, we did take a lot of doctors and nurses and in some cases turn them into data entry specialists. And it's kind of now that we're on the precipice of all of those next layer benefits of all of that coming back around. And I'm going to get into a little bit more what we're doing with AI to specifically address what he was saying earlier about, hey, I need to be able to prepare as I'm getting ready to see the patient. Well, AI can do that for you. AI can take all of the data from years of that patient's record and summarize it and put it in context for what you need to know as you're going in to see that patient right now. While you're caring for that patient, you don't want them staring like this, like you mentioned earlier. And in fact, today, they can take their phone, set it between them and the patient, have the full session, and let that be the thing that takes the notes, summarizes the information, stores it into the record, and then we need to take the next step of actually, simplifying the process and the follow-up. And so, I'm sorry, I'm taking a little bit more time for my introduction, but that's the things that we want to make sure we're addressing going forward with getting out of this just being digital record and actually creating access out of that.
Thank you very much. And as a provider, I certainly do appreciate the thought that providers should be part of this conversation. So, Ms. Baronio?
Thank you. And thank you for having me here today. I'm here today representing the National Association of State Mental Health Program Directors. So that association represents state leaders in every state, and some of our members are on the prior panel, who lead the state public programs to address the needs of some of our most severely disabled and impacted people who are most impacted by behavioral health conditions. And so we think about these issues more from the system level and, kind of how the different programs interact or don't interact. So my role at NASHBID is I'm a senior advisor, and I'm primarily focused on funding streams, Medicaid, SAMHSA, Medicare, et cetera, and thinking about, advising state officials on what the opportunities there are, what the limitations are. But in terms of the importance of this issue for our members, it's incredibly important. As the prior panel highlighted, there's a lag in terms of the use of IT, and your data brief also really illustrated this well, that particularly for state-funded programs, there's a lag in terms of using IT for care coordination, which, as we know, is really critical. People don't just come with one single diagnosis. They generally and often have comorbid conditions, and the interaction between those conditions, we know from research, really affects outcomes and cost of care. So for the most severely impacted individuals, those with serious mental illness who often have very serious physical health conditions as well, the impact of those behavioral health conditions on physical health outcomes is very costly. And we know this from research, but nobody tracks it, as others on the prior panel also highlighted. This is very important, and improving the coordination of care for those comorbid conditions is very, very important, as well as those transitions between levels of care, as the doctor from Louisiana highlighted, very, very important for our members. And I'll just leave it at that for now, but thank you for having me.
Thank you very much, and we will certainly be digging more into the care coordination piece today. Ms. Brown.
Hello, and thank you all for having me. My name is Stephanie Brown. I am the President and Executive Director of CRISP DC. We are the District Designated Health Information Exchange, a 501c3 nonprofit right here in DC. I am, by my education, a public health professional and focused on policy, and I always joke that I don't know how I ended up in health IT, but how I did was because of everything we've been talking about today, that the movement of data is essential for whole person care, and that means it needs to be all of the data, and that's something that the HIE here in DC is focusing on. So today I will be diving into what we're doing in the behavioral health and mental health space, but we are also focusing on other creative ways to move data in the district, such as the DC-led registry and school absenteeism data for the coordination of whole person care.
Thank you very much. Ms. Newton?
Hey! Very loud. It's great to join you all today. I am Ashley Newton. I am the CEO for Centerstone's Institute for Clinical Excellence and Innovation. I represent a provider organization. Centerstone is the nation's largest behavioral health or community organization. And we have brick and mortar facilities in 9 different states. We also offer a 2,000 licensed clinician network of services for military service members and their families across the entire United States and in 26 other countries. The Institute is the part of the organization that gets to really dig into research, clinical practice, setting those practice standards, helping our staff to be comfortably competent, utilizing evidence-based practices, We also run what's called Centerstone Patient Safety Organization. And so this theme of data is not only connected to how do we deliver the very best care, but it's also connected to how we can utilize our lived experiences and decades of practice and patient experiences to also shape what care looks like, and to understand what kinds of interventions work and for whom. So this is very near and dear to the work that we do. I've spent the first 10 years of my organization really working in clinical practices in communities. I'll talk a little bit more about that with the next question, I believe. And then the last 10 years, I've spent really working in this research and innovation space, and also trying to help shepherd clinical technologies and decision support tools into the EHR. So we have a lot of experience with both the kind of the data mapping and the technical requirements there, introducing that to new providers who are learning to utilize new tools, and then also thinking about things like how do we overlay, safety science, for example, with the way that we think about designing records and tools for clinicians. So I have a heavy interest in that space too, and find that to be really, there are a lot of lessons learned, but I think it's been really fun to be able to dig into that. There are also quite a few constraints and barriers that we run into, and so I know those will come up today on this panel.
All right, thank you very much. I've seen some themes develop already, one of which we blow the microphones out when we talk, so I apologize about that. The other is that most folks on the panel, it seems like we have a lot of similar thoughts and a lot of lines of thought. Very friendly panel, so with that, I think I will just switch to first names if that's okay with everybody. Quinn, would you like to go next?
Hey, good morning, everybody. It's great to be here. My name is Quinn Bastian. I'm a psychologist with the VA. I came to VA originally as a operational leader for a small hospital in Washington State, and then eventually came over to VA Central Office, where now I serve as the National Mental Health Director for Informatics. We had some conversation between Dr. Jonathan Nebeker, I don't know how many of you know Jonathan, but between he and I about whether it ought to be the informatics side of the house or the clinical side of the house that came to represent this panel today. And we ended up falling on the clinical side of the house. So I work within the Office of Mental Health. The Office of Mental Health, which is part of the Veterans Health Administration, but my team and I oversee a portfolio of informatics tools that range everything from testing products to mobile apps to everything in the electronic health record in the mental health space. Thanks.
Thank you very much. Interesting debate. Dr. Nebeker still practices, so he's kind of clinical too.
Right. We both have our feet in both sides of the camp. That's right.
All right. Dr. Postal, Susie?
Am I on? Okay. Hi, everybody. Thank you for the opportunity to present today. I'm Dr. Susie Postal. I'm the Chief Health Informatics Officer at the Indian Health Service. And I also would like to recognize Dr. Glorinda Segay, who's with me today, and she's the Director of Behavioral Health. Within the Indian Health Service, we are recognizing the American Indian and Alaska Natives. There's over 2.6 million that we provide services to, and we represent, we listen to the 575 tribes. We are a healthcare system. We have a strong behavioral health care program. We recognize from this morning's discussion a lot of the same kind of concepts and concerns that come up, but to just recognize the need for technology to improve care and utilizing these tools. How can we make it more efficient for the provider? How can we use interoperability, health information exchange, and more for our patients, recognizing traditional health and also recognizing the special, unique cultural sensitivities of our population. Thank you.
Thank you. Nathaniel?
Hi, Nathaniel Counts, Chief Policy Officer of the Kennedy Forum. The Kennedy Forum was founded by former Congressman Patrick Kennedy, who heard from last panel, and his wife Amy Kennedy. And it was founded to really carry on their legacy and their work to stop the mental health and suicide crisis in this country. And so in the Kennedy Forum, we have this vision. It's called 90-90-90, and the goal is for, by 2033, 90% of people screened, 90% of people receiving the evidence-based coverage, the care they need, and 90% of people in recovery. And to that end, throughout this panel, I'm going to relentlessly hit on the importance of interoperability to value-based payment, which is really sort of like the workforce for accomplishing this. So no matter what I'm asked, that's what I'm going to talk about.
All right, good to know.
Holly? Thanks so much, Holly Carmen, Senior Compliance Manager for Qualifax Systems. I have a long-standing career with Qualifax. We are an EHR vendor of the CareLogic, Credible, and InSync platforms, and our specialization is supporting behavioral health, substance use disorder, and human service organizations. Thanks for having me today.
Thank you. Tim?
Excuse me. Tim Clement from Mental Health America. We're the country's oldest mental health advocacy organization, founded in 1909 by Clifford Beers, who had been suffered greatly in inpatient psychiatric facilities in the early part of the 20th century, endured some barbaric treatments, and I think we all look back now at some of the mental health treatments that were done, particularly the inpatient realm, facility-based realm in the 20th century, and look at them as, rightfully so, as horrific, barbarous, torturous. But I think one thing to remember is the people, the practitioners at the time, didn't think that. They didn't think that they were hurting people by submerging them in ice baths or extreme heat or performing lobotomies on them. I mean, I don't know if Patrick is still here, but they didn't perform a lobotomy on Rosemary Kennedy because they were trying to harm her, but obviously it did. So I think that's the perspective we bring to the conversation, is that we know everyone has the best interest of those with mental health conditions and substance use disorders in mind. We want to make sure that actually happens. And there's something I will bring up during our conversation just to emphasize that. But that's our perspective at Mental Health America.
Thank you. Megan?
Hi, I'm Megan Gilmore. I'm the Vice President of Government Affairs with the Association for Behavioral Health and Wellness. Our members are health plans that manage mental health and substance use disorder benefits, covering 200 million lives, both in the public and private sector. And so in this context of our discussion, looking at interoperability, data, information exchange, moving beyond kind of administrative to the measurement informed and outcome, kind of how do we get to value?
All right, thank you very much. Okay, we will move into some discussion points quickly here. So, Quinn, I'm just curious, what strategies does the VA take to leverage internal and external EHR data to improve mental health and substance use care coordination for veterans?
Yeah, thank you for the question. The VA is doing a lot. We historically, as an agency, we've done pretty well internally, meaning within the VA. We may have a legacy EHR that has 155 different instances of the EHR, but at the end of the day, all of those instances send their data at the end of the day to a corporate data warehouse. And we've been able to leverage that corporate data warehouse to pull data for a lot of very useful things, for clinical decision support, such as the ReachVet initiative, which uses predictive analytics to identify veterans who, based on what's in their EHR, are at very high risk, statistically, of suicide. So that we can then outreach those veterans and make sure that they're engaged in care. We've used this data for quality measurement, for measurement-based care, for all kinds of things. So internally, it's gone pretty well. The challenge is externally. With any of you who've worked with the VA know that it's been kind of a challenge to actually collaborate and communicate and share records, exchange data and other information with external partners. We've been pretty good about billing data, but beyond that, hasn't really gone so far. I believe we are at a real inflection point right now. I believe we are poised right now with almost a perfect storm of opportunity to make some significant changes in this, not just within the VA, but nationally. And here's some reasons for that. One is the speed at which technology is moving. It's moving so quickly. We've got a lot of opportunity to make some significant improvements with data. Number two, the administration. The current administration is very passionate about this, and that does include the VA administration. Our secretary has made it a top priority to really work better with the community and collaborate more with the community rather than just sending vets to be seen in the community, and then there's no communication between the agencies. And there are other reasons why I think we're so well poised to do this. One of them is VA's migration to the federal EHR. That there was a decision made years ago that VA needed to move to a single instance of an EHR that was a commercial EHR that would then become the federal electronic health record, and that is the Oracle EHR. Just last week, I spent time in Michigan helping 4 more VA sites migrate to the new federal EHR. So they're now in their first week of learning this new system and transitioning from the old system to the new one. That brings us to a total of 9 so far. We will have all VAs converted to the federal EHR within a couple of years. That inherently brings with it some new connections with the community that we never had before. Engagement with the new Joint Health Information Exchange that has more than 10,000 hospitals, labs, and other organizations already interfaced through the Oracle system with VA so that we can really start to share records in much more meaningful ways. So I think we're in a really good place for doing this, but it begs the question, and this is kind of my key stomping point today that I'd like to make. So what? Let's say that we do a great job of creating all this interoperability between our data. Let's say that we can share all of our data. What is the value? How does that actually lead to different mental health and substance use disorder outcomes? I think is a key issue. And so we've got some thoughts about that. And I think one lens to look at it through is to say, well, what kind of data are we actually sharing? So from the VA's perspective, at the most surface level is just a question of, is this patient sitting in front of me a veteran? There's a study from Duke that showed that if a community provider knows a veteran is sitting in front of them and that this person is eligible for VA benefits and VA care, that can transform their healthcare significantly and lead to better mental health outcomes. That clinician, that system knows that this person is eligible for suicide-related care, for example, through the Compact Act and other legislation. So just knowing that somebody's a vet is a starting place, but that's not really enough. If we dig a little bit deeper, we get just past knowing somebody's a veteran to actually sharing records, diagnostic assessments, treatment plans, other records of care. This can help us actually collaborate as a community in developing a shared joint treatment plan. So we're actually all working from a single community treatment plan as opposed to a different treatment plan at each agency or each stop along the way that a veteran may go through. So that's another step. I think we need to go further than that, and it's been talked a lot about today, to go a little bit deeper into if we do commit as a community to collaborate in how we provide care for substance abuse and addiction, how do we know if we're doing it? How do we actually know that we're doing these actions, taking these steps that are showing that we're collaborating and working together? And that brings us back to the measures, to having a standard set of digital measures that are built into the EHR that help show if we're actually doing that. And our agency is working collaboratively with a lot of folks here, including ONC, to develop a collection of digital quality measures that can assess things like, are we actually providing warm handoffs between agencies? Are we making sure that veterans have continuous opportunities for care? And maybe above all, are we actually, as a collective group, carrying out the work needed to follow the clinical practice guidelines? Are we actually working on the same treatment plan, and is it consistent with the evidence? Things like titrating medications across agencies, imagine that. Things like being consistent with psychotherapy and the delivery of evidence-based psychotherapies across agencies, things like that. So it's very important to us. We think this is really key that we get to this point of digital quality measures. And then one more level below that is when we actually start talking about clinical outcomes. When we're really working together as partners, including with the veteran or the patient, to identify whether we're actually making a difference in their life, whether not, and as was mentioned this morning, not just symptom reduction, that's important, but it's not everything. Whether quality of life activities are getting better, whether from the perspective of the patient, there's improvement and recovery actually happening, and life improving. So tremendous opportunity right now. We're at a great inflection point for making a lot of difference. There's also a tremendous amount of work to be done. Thanks.
Thank you. And I think you highlighted an excellent point, which is interoperability in of itself. It's just the means, right? It's not the ends. It's like, what value do we bring? How do we improve outcomes? How do we improve people's lives? And so from your perspective at IHS, can you explain why the exchange and use of health data is so important for mental health and substance use, case care, and outcomes in tribal communities?
Sure. Thank you, Jason. First, I want to go backwards just to recognize that we, as well as the VA, are going through an HIT modernization. So we currently have, within the federal side, a resource patient management system, which is a spinoff of the VA, but versus we're cradle to grave with our EHR. And our new system, which will be Oracle Health, I look at Steve over there, that we have a strong group of users, not just within the headquarters side, but all over the whole Indian country, providing input to design this to meet the cultural sensitivity needs and more. And we also have a very strong telebehavioral health center of excellence for telehealth. So I just want to say, so what do we feel could the data exchange? The exchange and use of health data is vital for advancing mental health and substance use in our tribal communities, and it's systemic. It will systemically collect the data, and then you can get a comprehensive view of what you need to do to address these issues and address outcomes. You could look at the demographic changes in age. We have patients who have depression, as you heard, substance use disorder. You can look at other critical factors to design treatment and manage it. And I always say you take the data, you use it with your own information, knowledge, and then you provide the treatment or the wisdom. So instruments or tools that can help the provider to make these decisions, make quality care decisions to help the patient, so important. And as you mentioned, it's not just the technology, it's the person at the bedside, it's the person at the clinic. And so then I'm going to go into my technology side, where we also mentioned telehealth, a patient portal, where you can empower the patient to be part of their care, to message the provider if the medication's having adverse effects. I think of the prescription drug monitoring plan when you have substance use disorder, that you can help to guide them versus have a fatal overdose. And then again, it's the quality decisions, but we also have to recognize with our patient population the cultural sensitivity, and that's making sure that we can meet them at their native language sometimes and more. So thank you.
Thank you very much. And you know what I heard you saying that what was really appealing to me is, you know, when you're dealing with true longitudinal care from a very early age to the end of life, and you're treating that patient comprehensively, right? I mean, that's an approach that we really need to be thinking about, and I'm happy this forum is here to talk about that, you know, stigma was a huge topic in the first lecture, which didn't really come up so far yet today, but it's a huge barrier that we have to deal with. And looking at mental health as just part of health, right? It's just another pillar of primary care, I think is an excellent step forward. And it sounds like that's what you're working toward. So I'm real interested, you know, Steve, I know that you have some thoughts about this, but how do you feel that treating mental health and substance use care as a whole person, what does that actually look like in practice?
So in order to treat the whole person, you have to know the whole story. We've heard several clinicians today talk about, you know, needing to have that information and about data that they're putting into the system and struggling with doing. But the reason they're capturing all that information is so that they have that whole story. And unfortunately, we rely sometimes, well, and I should point out too, AI, we talk about all the benefits that we're going to achieve from AI. The AI is only as good as that data that we've input into it. So it needs that whole story as well to really tell the true story of what's going on. And unfortunately, we're relying on memory sometimes. When we go out and care for a patient in their home, maybe that patient has memory problems. Maybe they can't speak for themselves. Maybe the family member isn't even aware of the time that they went to the ED 6 months ago and were prescribed a certain medication. So we need all that data in, but we also need it to be liquid and interoperable so it flows to the caregiver and the provider so they know that whole story so they can actually care for that patient. And so that's ultimately what's going to allow the AI to show the full context to the caregiver in the situation that they're in. We're also relying on memory of the actual provider who, as we mentioned earlier, is struggling to pay attention to the person that they're caring for and take those notes so that they don't forget it later. And then taking that note, maybe they already cared for 9 patients that day, and they haven't gotten back to that note that they did at the beginning of the day from their first session. And then they have to go to their kid's soccer game, and now they spend the evening in their pajamas trying to remember what it was that patient told them at 8 a.m. in the morning. And so that's where, again, AI can take that out of the equation by capturing the data during the session, recording the information, putting it back into a note, presenting it to the provider and saying, hey, here's what I heard. Is that what you heard? And allowing them to just acknowledge what they've seen. So now, again, they've had the entire story of what they've experienced there. And I should say this is not, you know, we talk about some of this is coming. The AI is here today to do what I've just described. We've got behavioral health providers across the country that are using it. We've got behavioral health providers in Southeast Texas that are using this, and they've told us that they're seeing an extra 2 patients a day because of the time that they've saved. So we've opened up access to more patients receiving care because of the fact that now they have more time to do this. And they said simultaneously that they don't have pajama time, that they're leaving at a regular time. The office is empty at 5 p.m. because everybody has actually had their notes already recorded and in the system. So another note about that is that they said that it captures the data. You know, the sessions in Southeast Texas are very often done in Spanish. The provider may be English as a second language. The patient is English as a second language. But they can capture the data, the session that's happening in Spanish, and the note is created by the AI in English. And so, and in some cases, the providers themselves have said that the note transcribed it into better English than they would have if they had to do that themselves. So there's another benefit then that note is being captured accurately and then shared with the other providers that are going to care for that patient later. So it is amazing the change. And I should say, too, statistically, we got another provider in New York, and they've said that it takes them 57% less time to document the notes from their session and 25% less time that they spend in their EHR overall because they've implemented this artificial intelligence. Now, when we start translating that into the next phase of saying, hey, let's create a treatment plan from AI. We already know the standards of care. We know the patient's history. Instead of making the provider build that treatment plan from scratch, start it for them. Show them, here's what you would normally prescribe for a patient with these conditions in this situation, and let them modify that as opposed to starting from scratch and taking all the time that it takes to build that treatment plan. So these are real-world benefits that are coming, but again, it relies on that whole story, capturing all of the data.
No, I appreciate that, and I appreciate focusing on mental health data, the capture of that data as being a unique experience that we have to really focus on. And I also, again, as a provider, can't say thank you enough for making sure that we have to remember that providers are part of this equation too, and their satisfaction translates to better care and better longevity and more physicians in the system, more providers in the system. So I appreciate that very much. Holly, look to you and ask, what are some successes and what are some challenges for EHR adoption in the mental health space and substance use space, those care settings? What have you seen?
So I don't think it's necessarily about the adoption of an EHR. I think it's some of the challenges that we see are posed by states themselves, or a lack of barrier to education for providers around interoperability. What does it look like? What does it look like in practice? How do we tap into things or state HIEs or otherwise? How do we look at data liquidity? How do we look at clinical quality reporting beyond just having to do it for MIPS or APMs or otherwise, using it for that value-based reporting? Behavioral health care and substance use-related care are not standardized like health care, which is what we see. Every state has different requirements and even payment structures, and even sometimes within the state there's different structures that we have to adhere to as well. So when we have organizations like CARF and JCAHO, which are wonderful and fabulous standards of care, they are still voluntary across the board. So we also look at, and this was raised in the first roundtable as well, there has been a recent update to 42 CFR Part 2, and it's been welcomed, and it's been quite a success, looking at kind of that one single TPO to share substance use-related data, intermingling and commingling within the healthcare record. But it's also its alignment with HIPAA really kind of creates that substantial connections to consumer coordination of care, national goals for data interoperability, and a culture of information sharing and only blocking when absolutely necessary. So I think I like to flip it when people say, oh, it's the information blocking language, and I go, how about a culture of sharing until I've got to pull it back, and I've got to have good reason to pull it back. So that open notes movement as well. But this cultural shift, I think, that we've got to take in behavioral health care, specifically with substance use disorder, to move from data strangulation, because we want to protect it, to data safeguarding. It's a cultural shift that needs to take place nationally. We want to overprotect it, but now with some of those new changes, I think it's our opportunity to look at how can we really use this data towards the goals and aims that we want to. So I think it's an ongoing challenge, but not one that we can't really overcome. Thanks for the question.
Yeah, no, thank you. And I think what you highlighted there with that sort of balance between, privacy and utility, right? I mean, I think it's a conversation we have internally all the time, and it's a conversation that continues to evolve and will continue to be had. But, I agree. Well, we're going to have to figure out a way forward so we actually can have some, actionable outcomes from what we're doing. And with that, Stephanie, you and I were talking a little bit before the panel, and as Quinn and I had just said earlier, right? Interoperability, it's the journey, right? It's the means, it's not the ends. And so, working at CRISP DC, I mean, how do you see EHR systems? How can they be designed and leveraged to advance appropriate patient and provider access to secure, usable electronic health information exchange in mental health and substance use care contexts, and particularly, how do we improve outcomes with that data?
Absolutely. I think that I want to, before I dive into the technology and how we've designed that to address those barriers, I want to say the main thing that we're doing and why we're doing it is to take that burden off of the provider, like you spoke about, and off of the patient, to remember that history and constantly capture that history and put someone through potentially that emotional trauma, again, of speaking about their history when they've already done so, and that's something that came up on the first panel. And so that is why we're here. So at the District Health Information Exchange, we are very excited that we are currently sharing behavioral health data through the district for all of the Department of Behavioral Health certified providers. And we are doing so because we've worked with EHR vendors who have been open and willing to share that data with us in a way that works for their technology and also their organization. So what we've made sure that we do is we have technology that has been made with the no wrong door policy. We will take the data in any way you can give it to us. We will support those large EHR vendors that have sophisticated technology. We will also work with those smaller organizations that have legacy technology and need more support on their end, as well as their vendors need more creative ways to get that data into the HIE. And in order to do that, we have taken an agnostic approach of how that data gets in here. So some EHR vendors have the ability to work with their organizations and capture that 42 CFR Part 2 consent in their workflows. And so we work with those organizations to make sure that data is tagged and it flows directly into the HIE because that consent has already been captured. For those mixed-use facilities, for those that are not only substance use disorder treatment, but may also provide primary care, we offer another solution in which we say we will take on that burden, that technical burden of parsing that data for you. So we will take all of your data before it's visible in the HIE, move that substance use disorder data into the sensitive document repository, and the non-substance use disorder treatment data will flow directly to the HIE. That does not need to be covered by that 42 CFR Part 2 consent. And so again, we have this agnostic approach, no wrong door, that we're able to support the EHR vendor and their customer in the way that works the best for them. And when it comes to that 42 CFR Part 2 consent, not only do we have the technology on the back end to store that data, we also built a tool in order to capture consent in the way that the organization would like to capture it. So if an organization does have the tools on the front end to capture that additional 42 CFR Part 2 explicit patient consent, they can do so and attest for that in the HIE and then allow for that data to be shown to their treatment providers. For those smaller organizations that may not have the technology or the manpower to do so, we have a 42 CFR Part 2 compliant consent tool within the HIE. It's a provider and care team-led workflow where the care team can sit shoulder to shoulder with a patient, talk with them through what it means to sign a 42 CFR Part 2 consent and the importance of that whole person care, document that consent within the HIE, and therefore release that 42 CFR Part 2 data to their treating providers. And we've done all of this in partnership with the providers and what their EHRs have been able to support.
Thank you. Sort of revisiting the unique nature of what we're talking about today, right? Again, we want mental health to be part of the vernacular anytime you're talking about healthcare, but we do recognize that it is separate in many ways with regards to data capture and its approach to it. Different patient populations also have differences in the way they want it approached. And so I'm just curious, and we have a minute here to revisit that. What are some unique considerations? We'll start with our federal partners first, but what are some unique considerations for serving our nation's heroes, the veterans, and our tribal communities of mental health and substance use in their treatment settings? And, how can we use technology in those unique populations to improve care outcomes? Either or.
Okay, thank you. So I first think about the unique considerations to take with our distinct patient population. And some of our patients live on reservations. They may be 3 hours from the latest hospital to get care. And so when you think about a consideration and access to care telehealth, so as I mentioned earlier, we have a very strong telebehavioral health center of excellence. But you also have to have the patient want to have that technology. And some may not want that type of care. They want to be seen in person. So cultural sensitivity. The other thing to look at is population health. And there may be teens who decide that they have a suicide pact and they want to, at 3 p.m. Perform something that could be very fatal. That you have the technology to alert the community, to alert the healthcare system that something's going to take place. And what was mentioned in the first panel about historical trauma. So we, within our patient population, have a history of historical trauma, and you want to treat, again, the wellness of the patient. So what type of apps are out there to provide support for that, even if it's meditation, with water running, things like that. So I wanted to bring that up, but integrated care is so important with our patient population. So when you think of substance use disorder and you think of just a routine care, that they can talk, and they spoke earlier about that if you couldn't see something and you took a medication and then they showed up in the ER and it was hepatic toxic, you have no clue. So we have to have that ability to give technology integration available. And then the last thing I'll mention is about consenting. So, you hear about opt-in or opt-out, and what type of consent will help support a broader care for our population.
Thank you. How about the veterans?
Yeah, thank you. So veterans have some things in common. Every veteran was once an active duty service member. And active duty service members are taught to focus on the mission at hand. And the way you get the mission done when you're uncomfortable or when you're hurting is you push it down, suck it up, push through the pain, soldier up, and focus on the mission. And you get the mission done. That can be an effective way to get operational missions done. It's not a very effective way to deal with addiction. It's not an effective way to deal with mental health issues. 20 years later, after you're done with your military service and you've transitioned to civilian life and you're staring at a dark wall in the middle of the night wondering why you can't sleep. So the stigma that is endemic in our culture with mental health and addiction issues tends to be amplified a little bit in our veterans. There's even a little bit less inclination to seek help in the first place. While they're on active duty, they're very aware that any medical or mental health issue could keep them from being able to do their job. It could lead to them losing their operational assignments. It could lead to separation from the military. And so they're very disinclined sometimes to share that information. So that stigma is particularly strong, I think, in veterans. Another issue is because they've made that transition from active duty service to civilian life, for many of them, that holds a deeper connotation of transitioning away from being part of the federal government and working for the federal government, and becoming a free civilian where they're not feeling the touch of that federal establishment in every aspect of their life. Ever since Vietnam, we've seen that a lot of veterans, once they leave service, are really anxious to be fully divorced from the federal government, which makes them less inclined sometimes to seek out help through the agencies that are there, through the public agencies, through the VA and others. So what about technology? What does this have to do with anything? Well, technology can smooth those transitions somewhat. For example, the advent of all the different things that are available for getting help in mental health space that aren't necessarily going to a clinician and getting medication or getting treatment, getting psychotherapy. Things like courses, online courses for mental health. Things like virtual reality. Eventually AI. None of those are treatments per se. Chatbots are not treatment, but they can sometimes soften that entry into mental health services in a way that makes it a little bit more comfortable for people to engage in the system and start being open to the services that are available to them. I mentioned before about knowing that somebody's a veteran. We can say all day long we want the community to know that somebody's a veteran, but if we don't provide the technology to support that, it's kind of an empty request. And that's why a number of years ago, the VA started really encouraging the Veterans Interoperability Pledge, the VIP program. We have now 20 different healthcare systems and 2 vendors, Oracle and Epic, who've agreed to help support this Veteran Interoperability Pledge. All it is a pledge that an agency will check to see if somebody's a veteran by submitting a call to the Veteran Confirmation API to just ask the question, is this person a veteran? And so by putting the API behind that, it makes it much easier for systems to build it into their regular, even automated workflows to be asking that question. One last example, when it gets to the point of measuring all the things we'd like to measure, the processes of collaborating care, the outcomes that are there, we need to make that as user-friendly as we can too. One thing that we've learned from migrating over to Oracle is if you make something the easy path, people are a lot more inclined to do it than if it's more cumbersome and more difficult and harder to do. So we've got to make this kind of measurement the easy path. We need a digital health platform that allows our clinicians inside the VA, outside the VA, with all of our agencies, and our patients as well, to be able to engage in this platform to collaboratively pull together this information that shows, are we doing a good job of collaborating care and are we getting the outcomes that we need?
All right, thank you. And again, the stigma aspect surfaced again, and I'm glad it did because I think it's worth discussing. And it sounds like the VA has some forward-looking approaches on how you address that. I'd be curious from everybody on the panel, what your thoughts are about, scaling that out beyond our veteran population and, beyond our Native American population to the general public. What thoughts have you had on it? What conversations have you had, and what are your thoughts going forward? It's a hard one, I know.
Some thoughts we have at NASHBIT about this have to do with really incorporating behavioral health into more integrated settings, at least for conditions that are not to that level where you need a very specialized treatment setting. And technology is key to that. HIT is key to that. So as the senator, I think, told a story about in small towns, everyone knows if you're going to the mental health clinic, I think providing better access in more integrated mainstream settings really does help to improve stigma and really teach people that behavioral health is really a part of your overall health. But in terms of HIT and technology and how it can support better integration, there've been a number of articles written over the years. There was guidance that CMS put out back in 2024 around how Medicaid can support better integration of behavioral health, and also some guidance that was put out specifically around how CMS how Medicaid can support the administrative costs of making some of these connections. So I just wanted to highlight that for you. And that guidance does go into some of the details around how technology can support telehealth, can support e-consults, and that communication between a primary care provider and a behavioral health provider, even outside the presence of that client. So just a lot of really good recommendations, I think, and the other guidance document I talked about has to do with Medicaid coverage of interprofessional consultation. That's the term used. So I'd recommend those to you.
All right, thank you. Any other thoughts? Okay. Yeah, of course.
I had my chance to talk, but I feel strongly about, stigma, and some patients may not be comfortable with having mental health providers who are not Indigenous. And so when we think of telehealth, and others may have concerns that they live in the same community as their provider, they run into them at the grocery store, it might be their psychiatrist. One of our providers had shared that by providing telehealth and remote access, they can meet with the provider at another facility, per se, and get the care they need and not feel that they're weak seeking this care. So that's just one of the things I think of. Thank you.
To piggyback off of that, I just wanted to highlight, interestingly, from the health information exchange side of things, we saw through our technical assistance efforts with substance use disorder, behavioral health, mental health providers, a deep concern on behalf of their patients because they know what they have endured at the hands of the stigma that does exist. And so their comfort in engaging with us as the health information exchange was something that was being tempered by their concerns of the stigma that their patients that they are so dedicated to face. And so it's very important for us to have robust technical assistance programs where we can sit shoulder to shoulder with those providers, help them understand that we are a nonprofit and we are here to serve them as our users and the patients that they're dedicated to serving. And we do understand the stigma and explain to them the technology that we have and how we take every step to protect all of the information within the HIE, but specifically in line with 42 CFR Part 2, and make sure everyone on the care team is comfortable so that they're not only engaging with me and sharing the baseline data, but they're continuing to engage with the HIE and use our data in their workflows and the coordination of care on behalf of their patients.
Thank you. And I'm again, the theme that I'm getting out of that is the coordination and the outcomes. And I really like to hear that. And I kind of want to, I'm sorry, Nathaniel, I know what you're going to talk about.
No, I think you're getting to us anyway, so I'll just go ahead.
Thanks, Tim. Appreciate it. So back to my thing on value-based payment. You just can't really have value-based payment in any way that allows for integration that serves the whole person without interoperable data systems. So that's just sort of like a fundamental challenge we face. We put out a paper, I think it was in 2019, looking at MSSP used to collect depression remission at 12 months as one of its quality measures. And so I did a review of all of them. The average performance was about 15% depression remission at 12 months. The average rate of random remission is about 50%. 3 ACOs achieved 100% remission. I like to go see where those are and attend them myself. And now with the new ACO reach, access, there's about 5 main quality measures, and there's a lot of ways to hit them, right? And if mental health isn't meaningfully integrated, there just won't be a possibility to try to build it as part of overall value-based payment and allow for integrated stigma-free care. And that's not because they don't want to, right? There's like a general problem with integrating specialty care as a whole, which like CMS and CMMI are relentlessly focusing on. But without access to interoperable data systems, you just like it's so much harder than integrating like oncology or any other aspect of specialty care. So to policy recommendations, and then I'll let Tim talk. I think the critical thing is to integrate financing for interoperable data systems into value-based payment models. So when you're thinking about designing, let's say, a Medicare model out of CMMI, and I think it's important that it have a chance at national scale-up. There's been a lot of small models that are tests but aren't set up for national scale-up. And I think there's a chance to make this case that by investing in high-quality interoperable data systems, it has an ROI that allows for national scale-up that fits inside of existing value-based payment models, so it can scale nationwide, and it's not sort of a one-off opportunity. Then as Kirsten started to hit on, within Medicaid, I think you could have the same system where you demonstrate that kind of ROI, and that makes it that much easier for states in their 1115 waivers to propose investments in interoperable data systems. And then finally, with all of this in place, I think health insurance, like health plan alignment, gets that much easier. And I think especially on that point, there's this always antitrust problem, right? Like they can't all work together on investing, interoperable data systems, or it becomes a federal violation. And so I think there's an opportunity for the federal government and states to work together to create this liability shield that enables, cross-payer alignment and coordinated investment. Like I think we've seen in a few states, like I actually think Louisiana and Rhode Island both did that for primary care. So this is going to summarize for the note takers in particular. 3 recommendations, all related to value-based payment and interoperable data systems, scalable Medicare models that work across ACOs, help for Medicaid 1115 waivers to states, and then help for multi-payer alignment, especially through antitrust yields, so that there can be coordinated investment. I yield my time to Tim.
Thank you, Nathaniel. Fun fact, Nathaniel and I basically traded jobs over the last 9 years. I used to be Nathaniel at the Kennedy Forum, and he was me at Mental Health America. But so just talking about stigma, and we all recognize stigma, everyone here in this room, I think, recognize stigma as a huge barrier to mental health care. But I think one thing, we often talk about stigma like as a miasmatic vapor that sort of floats in the air and harms people with mental health conditions. But if you look at the research literature, it's defined as stereotypes, prejudice, and discrimination. So I think we have to remember that For instance, in the small town where everyone knows that you're going to the mental health clinic and you don't want to go, why? Why don't you? Well, there's that stereotype that your neighbors might endorse that you're dangerous or you're incompetent, you're not going to get better, they can't have their kids around you, that kind of thing, so you're not going to go. You're worried about prejudice or potentially losing your job, that kind of thing. And so that's one thing we have to remember about the stigma when we want to address that. There's lots of ways to do that, but until you address the actual underlying components, it's hard to get around that. And there are some evidence-based strategies to reduce them. I know the VA has actually been really good in doing what are called contact strategies, videos with veterans talking about their experiences with certain conditions. That helps people destigmatize and understand that individuals with mental health conditions are not necessarily the stereotypes they had in mind. But one way it plays out in the health records world, electronic health records, is that there's a phenomenon known as diagnostic overshadowing. So if you have a mental health condition on your medical record, you're less likely to receive appropriate medical care than if you don't. And so this has been confirmed by many research studies, including a very, very large one in 2006 by Druss and colleagues, hundreds of thousands of participants in the study. And they found that with a mental health condition on your health record, this was not EHR necessarily specific, but just your health record, you were less likely to receive a revascularization procedure after a myocardial infarction than if you didn't have that diagnosis. And they controlled for every potential confounding variable they could find, and it still held true. So that means if you have a heart attack, you're less likely to get needed care with the mental health conditions than if you don't. So that's literally life and death, and that's discrimination. That's the stigma. So that's why people don't want that diagnosis on their health record, because if you have a heart attack, you're more likely to die than if you don't have the diagnosis on your record. So that's something, I'm not saying that there's a solution to that in this room today, but it is something we have to keep in mind. And just the last thing I'll say about that, it's one way this manifested itself in electronic health records. It was about 10 years ago, a little over 10 years ago. There's a JAMA article about this in 2016. There was a health system that on their electronic health record, certain patients would have an airplane symbol on them. And so what did the airplane symbol signify? It signified that they were a frequent utilizer of either inpatient psychiatric services or emergency admissions, ED admissions for a psychiatric condition. So that's the stigma actually being actualized in an electronic health record. So that's the electronic health record basically saying to the provider, you should treat this patient with poorer care because they're a frequent flyer. They're less likely to, they're probably faking it, or it's just a symptom of their mental health condition and not a real thing. So anyway, that's just something we all have to keep in mind when we think about, integrating the health records, interoperability, and mental health conditions. Thanks.
To Tim's point, sometimes the stigma is actually keeping them from physically coming into the clinic because of what they may, what their neighbors may see or what their neighbors may think. And in some cases, we have providers who are actually going out into the community to care for patients. And the VA is one. VA has a home-based primary care where they do that not just for the stigma or for behavioral health, but to go out there for primary care purposes for those veterans who just cannot make it into the clinic for some reason. But we also have clients like the NHS that have community care trusts where they send people out into the homes. And they're actually in the process of combining acute, mental, and community care trusts into one trust where they can share the data across. But the point is, when you do that, you need that EHR to travel with the person out into the community and for them to have access to their EHR, even in places where they may not have internet access. And so that's where, something we've seen successful is the implementation of that technology on smaller form factors with full access to the historical EHR, again, in the community, regardless of whether you have internet access or not.
Can I just add quickly too, sorry. I think one thing that I haven't heard, and I didn't think about it really until listening to colleagues here, is we haven't really talked about crisis either today. And I think we haven't talked about how do we integrate that information. We've really moved away from law enforcement responding to mental health or substance use by, trying to advance and improve our crisis response system. But I think in the context of our conversation today about integration as well as technology, I think that's a missing piece of this too. And it's a difficult one to kind of solve for. I mean, we're looking at how do you integrate with primary and other specialty care, and I agree with what everybody said, but that's another area that I think has a lot of exploration that needs to be done too.
Thank you. Please, Holly.
Yeah, I think the piece that I want to hone back on too, that we in the behavioral health care and substance use disorder world, what we live and breathe on a daily basis is what we're all talking about as a person behind all of this, right? And there's that adage that we've all kind of, if you're in the behavioral health world, nothing about us without us, right? And I think that we need to look also at, while we're looking at interoperable systems for providers or healthcare systems or crisis services or whatever, what does the consumer interaction look like? How are they able to kind of make that portability? How can they use an app ecosystem to be able to maintain that hub of their own healthcare ecosystem where they are the kind of central hub? So that interoperable data not just goes to a provider sense or outcome sense, but really looking at how can I enter a PHQ-9 in my client portal before I go see somebody, or those types of different things to be able to do those outcomes, or to be able to use, whether it's my colleague Stephanie's local health information exchange, or looking at TEFCA's QHIN network of networks of exchange networks. So how do we also empower and engage the provider, but then also empower and engage that consumer as well? I think that's an important topic that we tend to forget about here when we get it deep in data. We talk a lot about what we're all doing, and then I think we forget about the person receiving the care as the hub of the healthcare ecosystem, which is a vital piece here.
Thank you. Yes, very much so. And I appreciate you highlighting that, because in the time that we have left, I was about to pivot to over here, Nathaniel, I promise. I really wanted to dig into, this care coordination piece, like why it's so important, how we design that into our EHRs and our systems, and then importantly, how from a policy perspective, we make that happen. We make that an advantageous thing to try to do and to design into systems and to support. So I think with that, if I could maybe pull something out from either Tim, Nathaniel, or Megan on that, like from the care coordination piece, the HR design piece, what can we do to really get down to that consumer, that patient?
I'm happy to start, kick it off, and maybe probably hear what others have to say as well, and bounce off some ideas. But I think, this is a theme that was in the first panel, and I know has brought up here as well, as having that core set of data as well. So not just process, but what are the functional outcomes, and how do we move toward that? Advancing, that those common core set of data that include behavioral health specific elements, enabling the data exchange as well across the fragmented systems. Technology is not going to solve the fragmentation in itself, but it's one of the solutions or the puzzle pieces. And I know 42 CFR Part 2 has been a core of this panel, and that's good for me to hear that from others as well. While the culture, I like the way that you had mentioned the culture shift there, and then there's good examples about how that has been integrated. It's not consistent across the country, and so I think there's still a lot of education, a lot of efforts that need to be made for all the stakeholders that are involved in the system around privacy, HIPAA compliant, as well as 42 CFR, and what's appropriate, what to share, what is not. What are the real changes? What are the laws and regulations around that? So while I think we've heard some positives with that, there's still, I think, some lack of knowledge, education, and resources specifically in that area. And then again, making those measurable, those metrics measurable and meaningful as well. So,
thank you.
I guess I could add in terms of why care coordination piece is so important. I think with individuals with mental health conditions and substance use disorders, there's a very high comorbidity rate with other medical and physical health conditions, and that works two ways. One, individuals with mental health conditions, substance use disorder, just one variable, for example, they have a much higher rate of smoking than individuals with that, particularly individuals with serious mental illness, which of course leads to all kinds of comorbid health outcomes. But then also individuals with serious chronic medical conditions are also much more likely to have depression or anxiety. So you do see this very high disease burden with individuals with mental health conditions and substance use disorders, particularly those with serious mental illnesses like schizophrenia and bipolar disorder. where there's a lot of comorbidity that is, which actually, from a payment perspective, individuals with mental health conditions, particularly serious mental illnesses, are much, much more expensive to cover from a health insurance perspective. But that's mostly because of the comorbid physical health maladies they have. In fact, it accounts for about 80% of that spend. So I think it's something that's the reason why you really need to have the care coordination piece, because you have to, not only do you have to address all of these things, you have to know about all of them too. And then also that comes with prescribing the various medications. And of course, with the 42 CFR Part 2 issues, there's that part as well in terms of individuals with pain who've gotten injured, who might be prescribed an opioid, but they have a substance use disorder treatment. That almost happened to Patrick Kennedy about 11, 12 years ago. So I think it's something that's why care coordination, that's just one reason, but that's a huge reason why the care coordination piece is so important.
And I'll just build. So I think since like 2011, but probably even before that, there's been this dream in healthcare for the learning healthcare system. This idea that networks of people are able to not just see how the person in front of them is doing, but be able to like integrate the latest evidence from the literature into the practice to get the right treatment to the right person at the right time, which is always like a great thing to say at meetings. And then at the same time, it's called practice-based evidence. Like as you learn something in treating people, it goes back up and becomes part of the overall evidence that you test elsewhere. So that's the idea of a learning healthcare system. And it's led to two like profound breakthroughs in the mental health area. So in first episode, psychosis and prodromal, there was this program out of, started with the NIMH and that was scaled called EpiNet. There's a PedsNet for pediatrics. There's one for bipolar. And there's these incredible networks of providers that like are coming up with breakthroughs like in real time and then figuring out how to apply them to different populations, which, has sort of like changed the trajectory of people's lives. It's quite profound. They are totally cabined off from every other system. Like it works well within their network, but without, interoperable data systems across the mental health field, it just like cannot even make it to everybody else. And none of these people are participating in value-based payment. Like they're not in an ACO as far as like, maybe they are, but I don't think they know that. And so it's so critical to bring this kind of like powerful approach to patient care that really provides people the best possible care as part of the overall architecture of healthcare so it doesn't get left out.
I think I want to add just quickly too. We talk about workforce shortages, and I think that care coordination and I think the technology and the interoperability can help with that. We know care navigators can help identify where there are providers and maybe that speak the same language, look and have similar backgrounds to the individual and what they're looking for, but also again leveraging telehealth and some of the other digital tools as well.
Can I just add something I forgot to mention earlier, a model for your consideration for improving care coordination, sort of a hub and spoke model, if you've heard of that. It's initially, I think, was in the opioid treatment space that term was used, but there's also a HRSA program that's sort of similar. It's called the Pediatric Mental Health Access Program, and it's really designed to create hubs of specialists that can support better access to care in other settings. And technology is a key piece of that and really supporting that kind of model, which can also address some of the workforce issues that Megan mentioned.
Thank you. Ashley, I'd love to get your take on it. I know you have a very data-driven approach and you have a lot of research you can share, and so what are your thoughts?
Thanks. I love this question, too, about care coordination. So I would say in addition to thinking about the data and research and support behind it, this was actually my first job when I entered the field. I worked in communities with children and their families and young adults and provided care coordination services to them. And so I can talk about the research, but I also have a very personal experience and have seen the impact that work can have for people in our communities. When I think about care coordination, I think about lots of benefits. I mean, for the patient, I think the linkage to services, learning how to navigate a complicated healthcare system or the rules for your insurance, knowing what your patient rights are. I did a lot of advocacy in schools also with children, and so your rights as a student, as a learner, as a recipient of care services. I think those are all ways that we can really start to address some of the social drivers of health, social determinants of health, like health literacy. And so that is something that I think care coordinators can also uniquely do because they can visit folks in lots of different care settings. And, Centerstone, we provide services in CCBHC settings, FQHCs, in communities. We have a hospital. We have outpatient services. So there are all of these ways in different spaces that people can engage in care. And I think in all of those, we have ways that we can impact their total health outcome, like especially focusing on the social determinants of health. That's about half of your total health outcome. And so I think this service is also one that when we look at the research around, the benefits of being able to have multiple care providers from different systems focusing on the same care plan. We've already heard that today. Having data systems that actually support care coordination and make that data more as real-time as possible available to both the patients and the providers. There's definitely an impact in terms of the workforce shortage and prevention of worker burnout. And so that's something that we look at, frequently. And when we talk about, metrics, we've heard several times that there's a real need for consistent metrics across behavioral health. And I fully agree. There's a lot of measure sets we can look at for guidance, but there's not really one single measure set that we've all prioritized together. But when we do that, not only do we benefit because we can learn and we can make sure that folks get the right care, we can also understand from a patient perspective what their outcomes are like and whether they're getting their needs met through that system. And when we actually look at the assessments and the kinds of outcomes that we're looking at, like symptom reduction with patients during their service, research also shows that they're more likely to come in and actually complete that episode of care, and they're likely to get better faster. And so I think, to me, all of these things are kind of interwoven in terms of what does the best care look like, and then what are the tools and the resources that we need to navigate that well. And I think that's really where the data and interoperability and stigma, so I thought the point that you made about sometimes it's not the fear of walking into the building, it's the fear of when all of these things are connected, how does that impact other parts of that person's life, right, or the care that they receive in other systems. I hear people, I know that from a data perspective, but I also hear people in a very personal way talking about that experience and how it's shaped, how they think about their children's health, for example. I think autism is another, like in the IDD space, where you hear frequently that while it's helpful to have services, sometimes it feels like you're penalized for having that label attached to you or a child in the system. And so there are a lot of considerations when we think about interoperability and what's really helpful there. I personally am really looking forward to any opportunities that we have to learn from our experiences and from patient experiences and to kind of factor that back in. Somebody mentioned practice-based evidence, which is kind of equally as important, I think, as an evidence-based practice, and really bringing those things together is going to give us the best shot at providing care that really works. Thank you.
As we sort of come to the end of our discussion here a bit, I kind of want to, Kirsten, you have deep policy experience, a lot of experience in CMS. I think the federal government in many ways is like a patient, right? We have different organ systems, and sometimes they don't always communicate well together or work well together. And so from a policy perspective, from an overarching policy perspective, not just ONC, what are some key levers that you would recommend to improve the utility and adoption of health IT? But really more importantly for me is, how do we improve outcomes with policy in this space?
Yeah, I think I mentioned, because I was afraid it wouldn't come up, and I think it's really critically important, this guidance that CMS put out in June of 2024, really kind of outlining the availability of enhanced match for state agency-operated IT systems. So really building the platforms at the state level that can connect all of these dots and really improve care at the practice level, improve coordination between the different, programs and systems. It's important to recognize that Medicaid can't pay for all of it, but it can be a really good investment, a good way to organize a lot of that interconnectedness of care that's so important. I think that it's also just really important not to just excuse behavioral health from participation in quality improvement, value-based payment because the IT isn't there. We really need to get beyond that. It's been used as an excuse for a long time. And I think that there are really challenges there, but it really does take more of a leadership, a federal, state effort to really make all those connections between different systems. A couple of examples. So the 1115 reentry, I was very excited to hear about that Louisiana is kind of on a track to get an approval there. That's a CMS Medicaid initiative to provide Medicaid coverage as someone's transitioning out of jail or prison. We know a lot of the people that NASHBID pays a lot of attention to and our members serve are the very seriously mentally ill, the people with serious addiction who often, unfortunately, get involved in the criminal justice system, cycle in and out of criminal justice system. But improving those connections is critical. And this Medicaid program, the 1115, to help states do that is a really important policy lever. But what I have heard that has proven very, very challenging, the most difficult sticking point has to do with the IT systems. So having criminal justice IT talk to healthcare IT, that's really difficult to make that happen. But even within the healthcare system, state and private, public, psychiatric hospitals, specialized treatment facilities that qualify as IMDs. Someone, I think the former First Lady from North Dakota mentioned on the first panel, that being a challenging issue in Medicaid, the lack of coverage in those settings. When someone's leaving those settings, it can also be, even if they're a Medicaid beneficiary, even though it's the healthcare system, there's a big disconnection there and people get dropped off of coverage. So, these kinds of cross-system issues, there needs to be a lot more support, and Medicaid can be a part of that, but it's streamlining access to that, I think, is really critical, working with CMS to help support state efforts to access some of that support, finding other ways to provide support for those kinds of systems that make those connections, but at the federal and state level is, I think, critical for improving outcomes.
Thank you. Thank you for pulling that together. Ashley, I know we haven't heard from you as much. Do you have any thoughts on the policy piece?
Yeah, I think when you look at kind of the state of electronic records and other tools in behavioral health and compare that to physical health, and we see pretty dramatic differences. And I think there's, when we think about parity and the lack of parity, I think there are a lot of ways as that shows up, but there are also some opportunities that we have in front of us. If I think about like high tech in 2009, there was an investment of between $25 and $30 billion into the physical health space. And that system is clearly years and years ahead of behavioral health at this point. And so I would think about opportunities to align some of the investments with the incentives that shape behavior. And there are lots of levers of change that we can consider when we do that. But, if you think about, for my organization, we were working on accomplishing the meaningful use measures at the same time that we were doing things like MIPS or PQRS, right? And one of the core themes that I heard, and across other organizations too, is that sometimes the penalty for not participating is still less than the incentive you might have earned for doing it and getting it all right. And I think that when we look at incentives that are based in like the Medicare market, for example, community mental health doesn't have enough, they don't have enough people that are Medicare recipients. And so those incentives don't speak loudly enough to those organizations. So I might look at if there were, changes in requirements, certainly around common metrics, the more we can move toward that. I love this no wrong door approach. It's real hard to pull off, even in just our single health system. And so often what we end up with, and keep in mind, like Centerstone is now the largest nonprofit behavioral health organization in the U.S., which is relatively new for us, but we have a lot of resources that smaller organizations don't. A lot of my colleagues, we came from smaller organizations. Centerstone was much, much smaller 20 years ago when I started. And I was part of the first team that piloted laptops in the field, if that says anything. But I think our systems tend to be kind of Frankenstein's together. We have an EHR, you put data in, It sometimes can prompt you to do things from a clinical perspective that are helpful, but generally you're having to go and retrieve all of that information. And the tools that help our systems to better communicate with one another, we're kind of bolting them on and having to choose them. And so I think anything we can do that moves toward a common framework for measures that aligns the incentives in ways that actually speak to and shape the behavior of the groupings or the organizations who need to make the change, I think that will help. And I think holding all parties kind of responsible to the same goals. So, we have the legislators, we have the behavioral health organizations or provider organizations. We also have vendors and technology partners. And so I think really focusing on what is the goal and can we all interpret that in a reasonably like the same way. So even if an EHR today can achieve interoperability, it looks really different from system to system, and we need them to be more of the same. And I think that the burden and the cost of that typically a large portion of that falls into provider organizations to figure out. And so maybe there are also opportunities to offer technical assistance or things of that nature to organizations who really are trying to make that shift, but doing so in, like I sometimes say, it's like the road is riddled with potholes. Like it is really difficult to make all of these things connect. And the more that we can offer and support and be really intentional about how we align the incentives, I think will go a long way.
Please, Nathaniel.
So I had a sort of a pitch that HHS could do tomorrow, which is easy for me to say because I don't work at HHS. But so there's like 3 giant VBP models running right now. Access, MSSP, which is always running, and then AHEAD, which I think is quite large, at least in a few states. And so like one of the biggest problems since CMMI existed is the selection effects. People who apply for the models are not representative of all providers. And so that makes it like very difficult to scale over and over and over again and defeats the nationwide scale up. And so I think the opportunity within these major models is to have every sort of like major healthcare system find a partner that's like a mental health and substance use provider that doesn't have an interoperable data system, and then apply. And so you have like quite a lot of applicants. Like it could even be like within Access, like different sorts of healthcare systems within it. Within AHEAD, you sort of apportion it up. And once you have enough applications, like really encouraging people to apply, you could then randomize it at that level. So it's not a mandatory model, it's still an optional model, but within randomization of the applicants. I think if that's carefully controlled enough, you could set up a logic where because you're tracking total cost of care, and not just siloed costs because we know mental health affects multiple areas, you would be able to find if it paid off within the window, and then you'd have enough information for national scale up. And then like, since as more VBP models roll up, it would just be just baked into it because it's assumed to be cost neutral. And I think that would create like one sort of massive scale up mechanism that's not, a huge new Medicare incentive system, which would be, first best solution. Second best solution is in VBP, specific recommendation for whoever the note takers are. Thanks.
All right, thank you. In my last job, I should have hired you for our research department. That's a pretty clever approach to that. I like that. In the time we have left here, I want to have the opportunity to sort of revisit anything we need to revisit. So if you heard something from another one of your colleagues today that really stuck with you or challenged an assumption you had, I'd love to hear that. Or if there's anything we just missed that's worth getting out here right now and talking about, I would love to hear it.
I think one of the things that we've talked a lot about, and I'm going to kind of not pick on Ashley on this one, but what you had said was it's a challenge, right? And I'm speaking more in that vendor sense. We want an interoperable EHR system, but we also want that flexibility, right? Because my behavioral healthcare agency looks like this and we do this, and so I want this workflow to get the outcomes that Nathaniel talks about quite a bit. And so in that flexibility of saying, when I go to this brick and mortar location, it looks like this, or I go over here, it looks like this, then how do we create kind of like systems? I don't think that we're ever going to get to that place. We all can't agree on one vanilla sugar cookie, right? I want chocolate chip, or you want snickerdoodle, or whatever it is. But I think that we're already creating that under ONC right now. You've got USCDI Plus for behavioral health care. So you're creating those data element and those vocabulary standards that we can all talk to when we do interoperable pieces, right? But now we need to define them. It's great to say, I want to see this in a behavioral health data set, but how do we define that data element? And I think that's a piece that I think we're struggling with as a kind of an ecosystem as a whole. But I also think that we need to look a little bit more holistically too, right? We have patient-facing apps that are sprouting up all over the place, whether it's through FHIR-based APIs or whether it's through other places. But HIPAA doesn't cover those. So how do we then get adoption to those? Can HIPAA then kind of go in and cover to kind of create that secondary layer of security as well, as long as we're doing different things? And I think that we also need to focus on cybersecurity. We've got the new revision hopefully coming out this year in regard to HIPAA cybersecurity and what that looks like, because all of us in the grand scheme of things, the more that we keep diving back into the IT ecosystem, I think it's important to kind of look at the safety of our data. So we want it to be interoperable. We want the kind of network of networks of being able to access things. We want those kind of prescriptions, those diagnoses, that ecosystem space, but we also want it to be safe and secure as well. So I think that there's a lot of things that are working so well in regard to health IT right now, but a lot of them feel still a little in their infancy, right? USCDI is still kind of chugging along, but we're not really pushing it in regard to certification. So does ONC have a space for that? When we look at the BHIT program, I'm looking at my colleague Stephanie because I'm working with her very closely on that in DC. How do we then kind of look at what does that pilot program bring to us in the behavioral healthcare space? When do we reflect on it a little bit and say, what can we learn from it, right? What did we grow from? What didn't work? We thought it would work really well, but it didn't. And then where's our areas of growth and opportunity? I think there's a lot of good places and spaces that we're already doing that I think we need to champion each other around. And there's a lot of ouchy points too, right? And I think that's kind of a good way to look at behavioral healthcare sometimes, right? But then I do think that there's some good successes out there that are already foundationally creating a floor for interoperability, AI use cases, and kind of all those different places and spaces that we've got out there. So not to be a Pollyanna about this, but I do think there's some good change going on in behavioral healthcare right now as well. Yeah. Thank you.
Thank you. No, I don't think there's anything wrong with being positive. That's not making Steve.
Yeah, something Holly mentioned earlier that stuck with me was the disparate nature of local agencies and the fact that the data that they capture, the standards for assessment, for what they need to capture in order to get paid under their local program is so different from area to area. So, I mean, and because I deal with the post-acute space, I can see it the other way too, where in the post-acute space, if I leave the hospital in LA County or upstate New York, I'm going to go for rehabilitative services for my fractured hip. They're going to capture the same information on me in both places because they're going to be paid the same by the same place. And so it's created an ability from a vendor perspective, to be able to support that standard of care easily everywhere and have our medical record be applicable everywhere. Because there are so many variations of the data that need to be captured in all of these local programs, it means that we can't support all of them, or we have to really dig deep to determine whether we're going to be able to support some of them before a client can come on board. And what ends up happening is that a lot of local providers that they become niche suppliers who are really good at helping the people in that area meet the requirements and make sure that they get paid, but they're not necessarily certified technology through ONC, and they're not necessarily as interoperable. They don't have the experience or the technology to be as interoperable as some of the larger enterprise vendors. And so somehow, we need to get to a place where we do establish, like Patrick Kennedy was saying earlier, standards of care and standards of assessment and reporting that are consistent across all of these disparate programs.
Thank you.
Sure, and I would like to piggyback off of that with minimum data quality standards. So as Holly has mentioned, we were awarded the Behavioral Health IT Transformation Grant. We're working with her organization on that, as well as some pilot organizations in the district. So while organizations are connected to the HIE, these behavioral health organizations, and they're sharing data, We are continually working with them and evaluating the timeliness and completeness of that data that we receive. And that is not just for our behavioral health providers, that is for everyone who participates in the health information exchange. But because of all of the limitations in the past that that the behavioral health providers have experienced, there is obviously a larger gap in some of the data that we are receiving from some of these organizations. So I do think it's essential to think about those minimum data quality standards and the data that the providers can see, because I can move the data. And however I move the data on the back end with whatever interoperability standards doesn't exactly matter to that primary care provider that needs to see the data that they need to see in order to provide that whole person care. And so from my end, I really would like to focus more on the data that we have and the data that we don't have. And through our public-private partnership with Medicaid, which has been mentioned here, they are who designates us in the district and have a significant investment in everything that we do within the HIE from our inception to now, through also these technical assistance programs that I've spoken about. We have made great progress in that. But if there was something that was standard and enforceable, it would allow that investment to go a little bit further, rather than the district specifically working on the data elements that our technical expert panels have decided is important. It could be something that could be broad and far-reaching.
I'll keep going, Ashley.
Thanks. I kind of want to piggyback off of both what you and Holly and Stephanie said, and just say, I think the extent to which we can land on a common measure set or the minimum standards for that will really go a long way. And CCBHC is one of the areas that stands out, and so in terms of areas of consideration, I think that might be one that we could look at and do more with. The other thing I wanted to highlight is, I was saying before that there are opportunities to align our investments with other incentives. And so there was a comment, I think, Holly, while you were speaking about, I kind of connected that to, digital therapeutics and other kinds of technologies that help us to provide better care and all of the new interventions that are supported in that way. And, I'll say, so I do a lot of work also around the reimbursement and regulatory environment for digital therapeutics and AI and other things. And a lot of my work over the last decade especially has been trying to help the organization actually start utilizing some of these tools in real world care. And the hardest thing, it's actually not getting it connected to the EHR. There's a technical solution for those. That has taken a while, but we are able to do that. It's the reimbursement landscape too. And so if we think about in 2019, for example, this was a project I worked on, CMS updated the codes for these for digital therapeutics, for remote monitoring and assessment, and it added clarity in hopes that that would incent or help providers to be able to utilize those tools. And as a provider organization, we're looking at providing services in 9 states and in other parts of the country. And at the level of the state, you have to wait for the state to actually adopt the code updates, and then you have to go through and renegotiate every single health plan to add those to your contract. And so when you have a handful of contracts, that becomes increasingly time, it's expensive, the time to do that and the complexity of the plans and the wait period. And so, and even then, early days in trying to build those, a very low number of the ones that actually should have been eligible for reimbursement were still not reimbursed. And so you kind of end at this point where you're like, is it worth it financially to add these codes, right, to be able to utilize these? Because of the burden that it takes to actually make those changes. And so when I think about that, I think about all of the different players involved and all of the different ways that we could shape our behaviors to get to that outcome. And so I think if there were more intentionality around how some of those rolled out, there probably are ways that you can also incent provider organizations to want to do more in those spaces, because it's pretty hard to convince people to add all of these codes to our health plans when the chances are it's not going to be reimbursed, and then the reimbursement rate is so low that it doesn't always make up for the time it takes to document. I mean, we've multiple times kind of been in that scenario, I think, as behavioral health providers, and there's, I think, probably a lot we could do to advance that if we thought together about the different ways that we could shape behaviors.
Thank you. Susie?
So I'm listening and everything. I was thinking, okay, we're bringing up FHIR, we're bringing up USCDI, and I'm like, oh, that's what I was going to say. And then you're bringing up the policies, and I'm thinking that's perfect, because I think of a couple things. We're going to be saturated in data. And then how can you consume the data and use it to look at trends, to make good judgment, and that was one of the things that came into my mind. We have business intelligence tools, as Patrick Kennedy had mentioned, a dashboard for each one of the different mental health kind of issues. We have the opioid surveillance dashboard within IHS. We have a telehealth dashboard within IHS. And how can you look at it real time to make decisions? The other thing that I was also going to talk about is with the EHR. And right now, our instance is where it sits at that site. But to have that integrated model, and then where ONC defines, I read all the rules, that's part of my role, the different types of, it's not called 2015 edition anymore, but the rules and criteria that you're putting into the EHR, so it is certified, so other people are measuring the same things within the whole country. Over. Thank you.
Thank you. Thank you. And Nathaniel, we'll end with you.
Oh, wow. So imagine, if you will, an RCT inside of a bunch of ACOs. I think the question becomes, like, what does it mean in literal terms to scale up, right? Like, you can't scale up some sort of like abstract thing within inside of a larger ACO. And I think the critical thing is not just to set it up as like this sort of like purchasing decision, but it needs to be a specific code, like a Medicare fee-for-service code, that let's say you can bill a single time to do this purchase. And then it becomes a test of that, basically. And if the test goes well, it's cost neutral, improving outcomes. Then across all of Medicare, you'd be able to build, like you don't for a mental health provider not able to achieve meaningful use, you can bill this one time to get the money you need to do your EHR purchase, and then like come in from the cold and begin to do, standard sort of mental health practice as part of these systems. But I think the critical thing is making something that can scale up nationally to make the rest of what everybody suggests works.
Thank you. And we've heard so much in the last 90 minutes from standardization of the elements associated with mental health, standardization of payer system, standardization of requirements. I appreciate the focus on providers, having EHRs that are appropriate for mental health and capture that data. And I especially, appreciate the prospective look of like, hey, let's make sure the money we're spending and the way we're doing this, we're getting the outcomes we want. Because I think we often fail in that. We're well-intentioned. We want the best for people, but the outcomes just don't meet that. And I think accepting that and trying to do it better is an amazing thing. And I appreciate the positivity that goes along with it. Because I do think with Secretary Kinney's leadership, it's a focus, and I think we're going to continue to push it through ONC. And I do think it is bright days for behavioral health, mental health, and substance use disorder. So with that, I'm going to remind you one more time, because I've been told it's really important. I got to let you know we're breaking for lunch, which you probably know because you're like, be quiet, I want to get out of here. The third roundtable will begin after the Secretary's remarks. His remarks start at 2 p.m. There's a cafeteria around the corner. In all fairness, I haven't eaten there, so I don't know if it's good or bad, but it is here. And but if you leave the building for lunch and you plan on returning, please make sure you give yourself enough time to get through security. The escorts will be available in the lobby starting around 1:30. And if you plan on being here for the Secretary's remarks, please make sure you're in your seats before 2 p.m. or you may not get to them. So thank you very much. Thanks for all the participants in the panel. It was wonderful. I appreciate all your remarks and your insight, and we'll see you soon.
Thank you.
Produced by the U.S. Department of Health and Human Services.